We're glad you could join us today for the ECG webcast, Keeping Pace on the Road to Value, Knowing Your Next Steps. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 90 minutes in length. Everyone should have received a copy of the session handout, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen at any time, and we will address them during our panel discussion. If we are unable to answer all the questions today, we will follow up with you after the session. We'll be launching an audience polling question as well today during today's program, and we hope that you will participate in this interactive measurement tool. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete this survey. For each completed ECG survey, we will make a donation, a $5 donation to Doctors Without Borders. So today's presentation will feature our colleagues from Doylestown Health, who will share key considerations and lessons learned on their journey to value. We'll hear from Jim Brexler, President and CEO of Doylestown Health and Doylestown Hospital. Dr. Scott Levy, who is the Vice President and Chief Medical Officer for Doylestown Health, and Sherry Putnam, Vice President, Strategic Initiatives and Integration for Doylestown Health. Now, working collaboratively with their physician community, they've established a clinically and financially integrated healthcare network that demonstrates value to the community and to the payers. Now, today's speakers also include two members of ECG's managed care practice, Rachel Bidgood, manager, and myself, senior manager, both located in our DC office. The ECG team has a comprehensive understanding of integrated systems of care and the payment mechanisms that support coordinated care delivery and value-based strategies. So together, we're going to show you today how organizations can optimize their participation in value-based payment models and position themselves to take on increasing levels of risk. Now here on slide 5, we have an overview of today's agenda, which covers 90 minutes of content and Q&A. We've already covered the introductions regarding the webinar. In the next section, Rachel will actually kick off the informative session. She will provide some background on the market dynamics that have helped to set the course towards value-based payments. And as I mentioned earlier, we'll also have a brief polling question at the end of this section so that panelists can understand where most of you are in your value-based journey. And then Rachel will also review the framework ECG used with Doylestown Health and other providers around the country in assessing their competencies and capabilities to exist and succeed within a value-based environment. And then in section 4 is where we'll not only get to hear directly from our esteemed panel regarding their value-based journey, but this is also when the audience will have an opportunity to ask questions of the Doylestown Health team regarding their experience and lessons learned. And then finally, Rachel's going to provide some remarks and a sneak peek into the next 2 sessions of this value-based webinar series. So Rachel, would you like to go ahead and get us started?
Thank you, Purvi. To help set the stage, I first want to review several market dynamics that ECG believes will accelerate the support for value-based payment models. While the COVID-19 pandemic has highlighted the need for providers to create alternative revenue sources, providers should also be aware of several other dynamics that will accelerate the movement to value-based payment models. Starting with the left-hand side of slide 7, over the past couple of years, there has been a shift from hospital to outpatient and from outpatient to ASCs that has been encouraged by the adoption of site-neutral payment policies by commercial payers in order to manage costs. Providers will want to consider models that can help protect them from the reduction in payment due to the site of service selected. The aging population requires focused care management and could benefit from high-touch programs. With higher acuity patients, providers will want to consider value-based care models focused on care management and prevention to help preserve the health of these populations. Even before the pandemic hit, we started to see the creation of multifaceted care teams. Value-based payment models can help organizations more creatively utilize providers in order to meet demand and maintain access. And while digital health is not new, the public health emergency has certainly demonstrated the usefulness of telehealth in improving access to care. In a matter of weeks, many of the barriers, including payment parity for virtual visits and the ability to provide telehealth to patients at home, disappeared. Plans to permanently expand telehealth reimbursement can help further scale care management functions, which are crucial to the success of value-based payment models. Lastly, there is strong support from the federal government to transition to alternative payment models, and commercial payers continue to follow suit as they too are focused on cost management. And despite the slower than anticipated adoption of value-based payment models over the past decade, we believe that the transition to value will happen more rapidly over the coming years, due in large part to the dynamics that I just reviewed. Here on slide 8, we have the 3 overarching categories of risk-based payment models, starting with the lowest level of risk of financial risk on the left-hand side of the slide. Payment models that fall in the developing category are generally a hybrid of fee-for-service and pay-for-performance, and generally with these models, the focus is on process and outcome-based measures. As we move along the spectrum to the transitional category, there's a greater focus on managing total cost of care for a targeted population through some sort of shared savings or shared risk arrangement. Examples here might include the MSSP program for Medicare or ACOs for commercial populations. And then finally, as we move down the continuum, there are payment models for providers or organizations that have a highly evolved payer strategy and highly evolved capabilities. And under these models, all payment is linked to the effective management of a population. Examples here would include a partial capitation or a full capitation arrangement, where there's a much higher level of financial risk based on whether the total cost of care exceeds the sum of the per member per month payments. And based on knowing and understanding these challenges, ECG utilizes a framework that Purvi mentioned to help organizations across the country understand which payment models are appropriate, either based on the organization's current capabilities, or we also use the framework to help them understand the competencies that align with the varying payment models and where they need to overcome some internal challenges to achieve their strategic objectives. And before I go into more details on this framework, I'm going to pause here and turn the presentation over to Purvi for a quick polling question.
Thanks, Rachel. Now, our polling question should be appearing on your screen, and the question reads, where is your organization in the continuum of value-based care delivery? Please select one of the following responses based on the stages that Rachel just described in the previous slide, which are developing, transitional, or highly evolved. Now, with developing, please recall that the way that we're defining developing is these are organizations that may mostly be in fee-for-service agreements, maybe some pay-for-performance. You also have transitional, where you may have started to take on some shared savings or shared risk arrangements. And then highly evolved is where you have organizations that have really started to focus on total cost of care and have a substantial portion of revenue that's based on full risk agreements. Okay, so it looks like we have a good response now. So let's close the poll and share the responses. So what we're showing is that 56% of the audience considered themselves developing, 44% considered themselves transitional, and actually we do not have any organizations that considered themselves to be still, to yet be highly evolved. And you know, to me, this is not completely surprising. I think there is certainly a pacing in this evolution. But Rachel, any thoughts on these results before we jump back into the presentation?
I would agree that this definitely mirrors our experience with provider organizations across the country. And as you mentioned, it's really how do you bridge the gap between being at the developing level and moving over to the transitional level, and also transitional to make the step to highly evolved. We'll go over a framework to help organizations assess, you know, how to make those moves. And then I think the experience of Doylestown, who's gone through all those stages, will really help everyone in the audience understand how they too can help their organizations move. And so with that, we will move on to slide 11. And again, to help organizations determine their current competencies and their capacity to exist within this value-based care environment, we at ECG have created a framework to help you all determine what your value-based payment readiness is. And while there's many factors at play, this framework is really meant to provide a comprehensive measurement of an organization's performance across these 6 specific domains, illustrated here as the spokes of the wheel. And so if we start with the 1 o'clock position, comprehensive provider network, the framework seeks to understand the adequacy, depth, and breadth of an organization's providers and the services they furnish, as well as an organization's ability to provide continuity of care. And so organizations are asked a series of questions really designed to determine the clinical scope of providers within their network and to what extent providers are able to access care across the continuum. Next, we have care delivery transformation, and here we're looking at the extent an organization has achieved operational efficiencies, system-wide coordination, clinical innovation, as well as the level of provider and patient engagement. A large part of this section is really trying to understand how well care is coordinated across providers and how organizations are using clinical protocols and pathways. Essentially, with this section, we seek to understand how an organization's care model can support potential risk models. Robust technology. So here, the scope of an organization's clinical and financial data, as well as its reporting capabilities, especially as it relates to the identification of care gaps, is really a key aspect of any organization's ability to succeed under a value-based payment model. Really, if an organization wants to take on risk, and I'm sure as many of you in the audience can attest to, you need to be able to proactively manage a population, understand the total cost of care, and establish reporting capabilities that allows your providers to intervene when necessary. Effective payment models. Here we're really looking at the extent to which an organization has experienced the value-based payment models, because that will influence its ability to take on subsequent models. For example, if an organization only has pay for performance contracts, then it really needs to demonstrate capabilities in the other domains before higher levels of risk should be considered. The aligned provider compensation domain seeks to understand the extent of a provider's compensation that's at risk, as well as the associated performance criteria and targets. We're really looking to see how well an organization's incentive structure reflects the alignment with clinical goals and strategies to make sure that everyone in the organization is moving in the same direction. And then, as I'm sure we are all well aware, transformation requires buy-in. So in order to understand the ability of the organization's leadership and culture to support value-based transformation, ECG asks questions about whether the leadership team is committed to making the necessary changes to guide the organization forward. And then lastly, while the 6 domains can help an organization understand whether or not it's ready for risk, it's equally important to consider whether the market is ready for risk. And ECG does this by evaluating market population, trends, competition, and most importantly, payer interest in value-based payment models in order to understand whether the organization is in a market conducive to value-based arrangements or if there will be external barriers that we need to work through. On slide 12, now that I've provided you all with a bit more insight into the domains that ECG looks at, here we wanted to provide you all with a more detailed perspective on what that output looks like across the capabilities in each domain. And what we find is that organizations will likely find themselves at varying levels of capabilities across each of the domains, meaning they can take on various levels of risk. And we really want to ensure that an organization has all the competencies it needs to succeed under the risk level it has selected. So if an organization is interested in transitional, so those shared risk and shared savings arrangements, we want to make sure that they don't have any gaps. And if they do, for example, here, robust technology they're still developing, we want to help them develop some plans to really get to that next level of capability. And most importantly, what we find is that the biggest driver of success is in aligning and pacing your clinical and financial efforts. So if you're focused on optimizing care delivery and reducing utilization, but your payment models aren't yet structured to reward you for that, there could be a negative financial implications, right? So if your clinical capabilities are in transitional, but your payment models are still in developing, you're likely leaving some dollars on the table. Conversely, if you have advanced your payment models, but you haven't structured your care delivery to align, you could be putting yourself at greater financial risk. So if you're in shared savings arrangements, but your clinical capabilities are still pretty fragmented, you're putting yourself at risk for losing some of those dollars because of the risk model you're participating in. And so on slide 13, once organizations have determined where their gaps are, they should really begin putting structures in place to ensure that their goals and priorities are met. And as I discussed on the previous slide, and as I'm sure Jim will speak to in just a couple minutes, buy-in and engagement from your board, administration, and physicians is really crucial to setting your strategy. You'll want to make sure that you have organizational structures in place that supports that collaboration and alignment. And then from an operational perspective, organizations should ensure that they have partnerships in place with other organizations to help ensure those care transitions, which is really fundamental to most of the value-based care programs that we're talking about today. And then lastly, all programs really should be developed with scale and sustainability in mind. It's crucial that the population is large enough to justify the investment that you're making in terms of time and resources. And that is particularly true since the lift to stand up information management can be great for many organizations. And finally, on slide 14, we have some of the most common challenges organizations face when implementing these programs. I'll outline a couple of the challenges and resolutions, but Doylestown will share how they've overcome some of these hurdles and probably share a couple other challenges again in a couple of minutes. So starting with the top, claims data is often lagged. So it's really important that organizations think about reasonable proxies for payment and costs in order to provide others in their organization with a more real-time reporting. Patient identification and tracking can be difficult, so organizations should really make sure to include this in their planning process because it can take time to develop those registries and flags. And you want to make sure that you're able to, on day one, that you're taking risks for that population, try to manage that population. Claims adjudication can be challenging as most organizations do not have the infrastructure to take on this risk. But in our experience, proactive providers can get more involved in prospective arrangements, giving them a little more control over the risk that they're taking on with downstream providers. Provider engagement is often one of the most important aspects of implementing a value-based payment model, and Dr. Levy will speak to this in a bit. So organizations who proactively develop a strategy and use physician champions tend to have more success under these types of models. And then program monitoring will help ensure that the organization continues to perform well. So organizations that have built a formal process are able to identify issues before they become larger problems that can derail the program. And with that understanding and that framework in mind, I would like to turn the presentation over to Purvi to set the stage for Doylestown's journey to value.
Great, thank you, Rachel. So before we get into Doylestown's journey and the stakeholders who have really helped drive success in that journey, we thought it would be helpful to at least provide you all with some background regarding the organization. So Doylestown Health is an independent nonprofit health system that's located in suburban Philadelphia. The flagship hospital, Doylestown Hospital, has over 250 beds and a medical staff of more than 450 physicians in over 50 specialties. The system extends beyond inpatient and outpatient services to also include independent living, skilled nursing, and assisted living centers. And then bringing all of this together to drive value is Doylestown Health Partnership, which is a CIN through which they've participated in 2 separate ACOs with significant savings and have earned significant savings earned and success. I know that Sherry will share more details regarding the CIN and ACO experience. But through their efforts in meeting the health needs of all members of the local and regional community, Doylestown Health has actually earned numerous awards and accolades, including being ranked 8th in Pennsylvania and 142nd in the US as part of Newsweek's annual list of best hospitals for 2021. Many of the members of their medical staff have been designated to the local top doctors listings, and they've also earned recognition as one of the most wired hospitals in healthcare. And they've also earned their 10th consecutive A grade for patient safety from Leapfrog. So now moving on to slide 17. In 2015, Doylestown Health underwent a comprehensive strategic planning process in collaboration with ECG. And as part of this process, Doylestown Health and ECG evaluated the value-based competencies across the system using the value-based readiness assessment tool, or the VBRA tool that Rachel just described earlier. Now, the VBRA really provided us with key insights that were then used to help the organization develop a cohesive approach in transforming the delivery system from a hospital-centric mindset to a system model. And it also helped them facilitate alignment with key providers and payers in the market. And now today they are a robust, value-based enterprise and are consistently reevaluating their capabilities in order to take advantage of new market opportunities. Now, the transition, however, started with a tactical roadmap, as you can see on the next slide. And this roadmap helped to identify and prioritize specific initiatives that were related to care delivery, physician alignment, informatics, and contracting. So essentially, this roadmap functioned as an implementation plan that helped guide Doylestown Health and many other clients in aligning their value-based strategies with the pacing that Rachel also spoke to, the pacing of the care transformation and managed care contracting efforts, and base those not only on future state objectives, but also their existing capabilities along the way, and making sure that those were also being optimized. So you can consider this slide a sneak peek into Doylestown Health's journey, but now I will pass it over to the team that really helped bring this plan to life. And we'll start with Jim Brexler, the president and CEO of Doylestown Health.
Thank you, Purvi and Rachel. We are honored to be a part of this presentation and to share our thoughts with you. First, most important thing we would want everyone on the call to understand is that we are in a journey, not at the conclusion of a destination. I mean, we are really still learning, and we're continue to be a learning organization. But it is intentional in our process to get there. We believe value-based care is actually the right way to deliver care. And so we have made that as part of our strategic plan and objective. When we set out to establish sort of what role we could play, and much of this was part of the strategic planning processes, as Purvi said, of Doylestown Health, we had to look at where we were in the marketplace and how we could remain sustainable in as an organization in an evolving market. And in this slide dictates sort of shows the map of where Doylestown Hospital and Doylestown Health is located in suburban Philadelphia. But one of the important parts of this is that we are located in a way that we're in the suburbs. We're a smaller community hospital setting, but we're surrounded by some academic centers. And our price point and our location gave us some advantages in that we were lower cost, and our medical community was very integrated and committed to our local community, which allowed us to be much more clinically integrated at the outset. In fact, we had a common clinical information system that all of our physicians, whether they were employed or community-based, were all on. So we were already engaged in some aspects of clinical integration. We also had a long history, a 25-year history of a PHO that had done some contracting before. So we had some elements going into this that sort of made sense. But the general market of Philadelphia had not really gone very aggressive into managed care. And so the question was, do we become a leader and position ourselves for value-based activity, or do we wait and react to it? And we made the decision to be proactive and establish ourselves as a value-based destination for care and for integration. Another element of who we are as a system on the slide before, as Purvi showed, is that we weren't just a hospital. We have a retirement community, skilled care. Our organization actually began as a home care agency almost 93 years ago. And so we have the full continuum of services within our community, and our medical staff is fully committed to that. So it gave us some starting points that were really helpful as we move forward. As you move on to slide 21, what we began to do then is establish in that roadmap some key things we needed to shore up, if you will, to make sure we were in the right position to move forward with this. And one of those was to take and really shore up the specialty services that we have, that we had a lower price but a high quality within the market, and begin to promote those as a destination. One of the issues that you find when you go into value-based contracting is that one of the opportunities you have is to keep folks inside your network as opposed to having them go to other locations, a keepage rather than leakage scenario. And for us, the more we kept business in these high-end specialties, we not only gained value in terms of the direct care and payment for those services, but we also had a less expensive cost when it came to value-based care compared to other locations where patients were being referred. So that became important, including the recruitment of some specialists to be able to shore those issues up. Another issue is that, most importantly, in a value-based world, you need to make sure your primary care base is strong and supported. And in many cases, we had small primary care practices that were struggling to make it. We began the process of not automatically employing all our primary care physicians, but we also wanted to make sure that we had an option for them so that they didn't end up in another network of care. And then we used, as part of the process of support, the returns that came from some of these value-based contracts actually came back in the form of payments to these practices, helping shore them up and give them more sustainability as well. And then the last issue is that we realized that while we're an independent healthcare organization, we're not an isolationist, and we need to find the right partners to make this issue work. And so we looked for others. At the outset of this journey, we looked at becoming part of an ACO, Medicare Shared Savings Plan. At that time, scale seemed to be really important, and so we joined a large ACO in our community. It quickly became evident to us, though, that if you don't focus on the deliverables to accomplish efficiencies within that model, it will not deliver the right kind of return. So we spun out of the large ACO and formed our own accountable care organization in partnership with another community hospital. And that's the ACO that was referenced earlier, that actually is the #1 performing ACO in the Commonwealth of Pennsylvania and in the top 15 in the United States. So on the next slide, which is really maybe the most relevant slide for you all today, is that as you move toward value-based care, and I see in the polling question, it was helpful to us. Some of you are developing, some of you are in transitional state. We are not in a highly evolved state, just so that you know. We are moving and trying to evaluate when we would go there. But we were in the developing state when we started this. We're now, I would consider us to be a more highly evolved, more than the transition state. But in doing that, we had to really help folks sort of wrap their heads around the idea that we are not going to be a hospital-centric organization, that what we really are is a network of care that is in partnership with our physicians and other community partners and other programs that we have within our system of care, and to become a very integrated clinical system, a clinically integrated network in the truest form, and that's what is presented to the marketplace, and not just your institutional place, your institution. that meant that we had to also sort of change our heads around the idea that volume is the most important criteria. All of a sudden, it became, how do we acquire covered lives? And through to get covered lives, you need to have a robust primary care community that knows what it's doing and can manage. You also have to create an infrastructure that supports that with data and analytics and care management protocols that extend beyond the four walls of the hospital and go out into the community. And you'll hear more from Dr. Levy as well as Sherry about the infrastructure investments that we've put in place. But one of the challenges, I will also say, and another expectation, is that when you're doing value-based contracting, the return on those investments come many times 12 to 18 months after the close of a contract year. I call it delayed gratification, that when in fact you've done all this work, but until all the claims run out and until all the adjudication's done and until all the other validations have taken place, you don't know how much your return is. And so you're spending money on one end to do the investments, and you're not seeing the return for some period of time, particularly at the early stages. As you move into value-based contracting, you need to think of working capital that is part of your investment toward this, and not look for an immediate return on these investments. But they will come if you do the right things. One of the important issues that we gained out of getting into value-based contracting, and particularly in the Medicare shared savings issue, is that we suddenly had access to data on the population that was going not just to our hospital, but to other institutions, so that we could sort of map out where the higher cost issues or where the challenges were, and could put tactics in play to put interventions to improve our overall performance. And then the last issue that I would just say on this slide that was important is that our relationship with the payer community particularly, but also with neighboring competitor health systems. We now are partnering with neighboring competitor health systems from a hospital perspective, but from a population perspective, we actually are serving a larger population and working together on improved flow of patients across the continuum, as well as flow of patients into academic systems that are doing quaternary work that we would not otherwise do. But it's also important that we've fundamentally changed our dialogue and relationship with the payer community, that now together we're trying to reduce the overall spend and improve quality of a population. And so that aligns us better. Now, I gotta say that this is a change in relationship for both the payer and for the provider. And it is still an evolving issue to determine whether or not we're still adversaries in a contract or whether we're collaborators toward a contract. But we are now developing new joint ventures with payers to talk about how we don't duplicate efforts in data analytics, that we don't duplicate efforts in care management and coordination, and that together we share in the savings and the return on those contracts. But again, that's a journey that's taken us several years. We've had to prove our worth. One of the interesting issues early on in our process is that many of these value-based contract issues start with a primary care focused activity. We believed from the outset that it required the entire continuum, including specialists, to be involved. And we had to do some negotiating, if you will, with the payers to put our entire system in a value-based agreement and not just have a primary care network attached. As a result, we have, in fact, we believe that's one of the secrets to our better success, is that it's a fully integrated across the continuum model of care. And so with that, I'm going to hand off to Dr. Levy and let him talk a little bit about one of the critical components, and that is how do we align the physicians in this model of value-based care.
Thank you very much, Jim. I appreciate that. On the next slide, is just a little bit of historic perspective, which helps us understand where we were and how we got to where we are now. So back in 1989, we had our independent physician or practice association, which is our physician organization. And we had the traditional PHO, which was the Bucks County Physician Hospital Alliance. In 2015-16, when we started to undergo this this initiative for our strategic planning, which resulted in Doylestown Healthcare Partnership, we had a perfectly good PHO, which had been doing very well. We had done some commercial contracting along the way back in the 90s. We also had done some interesting things, including some lobbying, a radio show in the Philadelphia market to really highlight some of our capabilities. And as most importantly, probably, we had created a clinical network, the Doylestown Clinical Network, where we had physicians of all stripes, employed, non-employed, specialists, and primary care docs. We used one EMR system, which was actually hosted by the hospital. All the physicians paid their retail amount for that, but the hospital supported that. So given the success of that, the question may rise why we decided to tear this down and start from scratch. And there's a number of reasons that are highlighted in the next slide, slide 25, which really goes and explains some of this. The PHO worked very well. All the physicians were participating through that, through the physician entity, the IPA. However, the physicians didn't have any direct engagement. It was all through that physician organization. And also, we thought a significant refresh in the type of structure was necessary. So back as part of the strategic planning, chose a group of about a dozen physicians who owned their own practices, both specialists and primary care docs. And we started having a group of discussions off campus in the evening to talk about where medicine had moved to in 2015. And these were physicians who knew each other well for many years, but hadn't seen each other in a long time. Siloing was a critical element at that time. Specialists worked in the hospital, primary care docs in the community, and other than a phone call or a quick message, there wasn't any face-to-face contact. And what came out of those meetings very quickly was the concept of clinical integration, not so much as a strategy, but just the yearning of these physicians to reacquire some of what got them into medicine engaged before. Primary care docs in our market were very heavily involved in value-based contracting and were very concerned and curious about some of the actions and activities of some of the specialists. Conversely, specialists were really concerned about some of the activities of primary care docs in attempts to reduce testing, et cetera, et cetera. And it became pretty quickly recognized the primary care docs had significant data on the specialists, in large part because of their value-based contracting. The specialists didn't even know the primary care docs had this information, and they certainly didn't have this information themselves. So it was an eye-opening to the specialist about how much available information there was about them. Very quickly through those discussions, it was appreciated that the discussion needed to be broadened beyond the group of docs who was beginning to meet. And the employed docs was obviously one of the elephants in the room that really required pretty immediate attention. There was some brisk discussions. Ultimately, the decision was that every physician is employed by their practice. A physician is employed by the organization. It's a larger practice, but the clinical involvement engagement is no different. And what very quickly happened, the physicians who were employed were invited to the table, not as a hospital constituent, but as practitioners. And that was a critical piece of the model moving forward, that this would be a true clinically integrated network to try to improve care. And the concept about leveraging contracts and considering value-based was thought to be something which would be, if well done clinically, if we could continue to provide high quality, there might be some financial rewards. But that was clearly a secondary consideration. As part of this, was also recognized that we needed a more robust electronic network. And analytics very early on was discussed as a critical element of this. So in the next slide, we talk a little bit about the final structure. And the Doylestown Healthcare Partnership, which Sherry will talk about in more details, is set on a couple of guiding principles. Number one, the hospital, the health system, and the physicians each own 50% of that. Physicians made a financial contribution to buy equity position in that entity. The hospital would match that dollar for dollar, so each had 50%. Specialists and primary care docs would each have an equal stake on the physician component side. So neither one could outrule. This wasn't a primary care driven entity where specialists were asked to tag along and had to earn the right to get the consults, nor was this the classic specialty practice or specialty group that was trying to leverage better contracts. Everybody understood the goal here had to be clinical integration. It needed to be driven by analytics. and it had to be driven by an EMR. One of the first initiatives that DHP undertook once formed was to choose an EMR vendor, which would create a platform for a network-wide solution. So we now have over 300 providers on the same clinical platform, as if it's one practice. Every clinical encounter is shared in every practice within our community, including our urgent care center, including our outpatient facilities, both specialists and primary care docs. There's one medical record that every physician participates. Part of DHP is governance, includes managing that record in a way that's fair and reasonable for everybody. And the challenge was to create that in a way that the individual practices still had firewalls for the billing and the financial components, separate obviously from the completely integrated clinical component. And that was very successful. On slide 27, I just wanted to highlight a little bit about the number of active committees. And this is not just a panel of committees that's there in paper only. Every committee appointed is just co-chaired by a hospital representative and clinician. And the makeup of every committee is balanced on both instances. Obviously, some of the financial are more heavily weighted towards hospital folks who have some of those resources. And every committee has subject matter experts included who participate and do a lot of the work who don't necessarily get to vote. DHP, after the first 2 years, completely covered all its own expenses. The hospital fronted those expenses with the understanding that as soon as the entity was able to stand on its own, the hospital will be reimbursed, and several $100s of back infrastructure costs were part of that reimbursement payment. I talked several times about analytics, and ultimately what's come to pass in DHP is it started on the understanding and the appreciation of clinical coordination and continuity and integration. The finances came second. And we continue to have this discussion. Is it a clinically integrated network with a financial component or a financial network with a clinical component? The financial success came as a surprise to everybody who bought a share of DHP. There was a hope that it would be somewhat reasonably successful. However, specialists really looked at the financial component as something to keep their primary care colleagues solvent and doing well so they could continue in practice. And the specialists obviously are looking to demonstrate the value proposition of the care they were able to provide and continue to get the referrals. However, when the finances became relatively robust, the dollars distributed were large enough that it even got the specialist interest. I want to talk a little bit about analytics and show you two quick illustrations of how we've used this. On the next slide, we talk a little bit about the clinical component to this. This is an old slide, but it's still very relevant. We created through our electronic medical record a risk dashboard, and we give each patient in the network, over 100,000 patients, a risk score, which is pulled not from claims data, it's pulled real time from the electronic record. This continues to evolve. However, the definition of a high-risk patient with a score above X is one that has a 15% chance of being admitted to the hospital in the next 30 days. And we continue to benchmark the metrics that we choose, as well as the score that we provide to assure that that definition stays constant. When I talk about admission, I'm not talking about a readmission. Obviously, a readmission requires you have a first admission. If we're trying to manage patients effectively clinically and also from a value proposition, we want to avoid that first admission. So the definition of avoiding any admission is critical, hence the creation of this dashboard so that any admission within 30 days reaches a high score. Every practice gets this list done every day for every patient within their network, and they're able to use this to proactively reach out to those patients to check for gaps and to try to ensure that those patients do not wind up with a hospitalization or some other complication. We have resources which in DHP, which helps provide clinical resources for those individuals. This has been an extremely powerful tool, not only for physicians to manage their patients, but we talk about rewards in our compensation committee. Being able to risk stratify every patient within the network allows us to risk stratify the various primary care practices based on their patient population, so that patient group doctor practices who have high-risk patients get credit for that when we do the compensation, and it's understood that they're going to have a higher rate of admissions to the ED, et cetera. Next slide talks a little bit about some of the compensation. It's very critical for the physicians to feel that everything we've done, they're getting value for the work they do. So physicians aren't going to be in a position where they're going to look to get rid of very sick patients because it makes the numbers look well. With appropriately measured complexity, we could correct for most of that. So this is something that we use for some of our compensation, and this is something that strikes home for the specialists. We call it keepage, and it's what percentage of the care various practice keep within the network. And that is not only testing and modality and hospitalization, but it's also utilization of specialists. Obviously, the specialists want to know that if they part of the network, they're going to be getting to work from their primary care docs. And appreciating that primary care docs' offices have different geographic locations, and some of the more distant practices will have more of a challenge to refer patients and those in close proximity to the main hospital in that center. We've actually stratified this based on how far the physician practices from the hospital. We did that by zip code and miles, so practice that's further, who's able to achieve a lower level of keepage, might do very well. Everything we do is in a control chart, so we could measure the statistical significance. And for compensation, we never reward docs for differences in practices that aren't statistically significant and don't fire a rule. So if two practices are very similar, one outlier isn't going to result in a significant payment in compensation at the end of this cycle. Every time we could demonstrate that every physician practice reward is based on a statistically significant difference from a colleague practice. And these analytics have been very, very helpful and have given a lot of credibility. Sherry's going to be talking significantly about some of the other modeling that DHP has done and some of the other work. Sherry?
Thanks, Scott. I think it's really challenging to set the payer contracting stage in 5 or 6 minutes when many would agree that this area has long been the proverbial black hole. But as Jim mentioned, a value-based approach really is a level set that gets providers to the table with a payer and gets us to a much better place, both clinically and financially. So some of the high-level lessons that we've learned, I've summarized here on slide 31 and apply regardless of model. The most basic of basic principles is really that access to claims data is the key that opens all doors. A primary reason to embrace value-based contracting with any payer, whether it's public or private, is simply to get access to your claims data. That ability, Scott talked about our access to real-time data on the dashboard to stage clinical interventions, but the ability to identify things like all-in costs across an episode of care, or understanding historic referral patterns, assessing which skilled facilities have the most reasonable length of stay that contributes to a cost. All these things are critical to being able to transform the way care is getting delivered and how it's paid. And of course, the ability to engage the scientific physician mind always has to be data-driven. Another key lesson for us was this notion of repricing for today's realities. We're probably all familiar with decades of typical payer contracting, those multi-year rollover deals with an inflation factor, focus on the inpatient rates, some lower percentage for outpatient. But these new value-based relationships bring us to the table in a much more timely way now with payer partners. We have proactively approached our payers with our own value-based contract offers, and we use that opportunity to renegotiate rates that reflects those real-time trends, like that switch from orthopedic surgeries from inpatient to outpatient, and the need to recognize observation status as more than just a fractional payment for the same services. So I think the second major message here is that timing is everything. Our suburban Philadelphia market's heavily dominated by one payer, and that payer had neither appetite nor incentive to share any risk or any savings with providers until fairly recently. But our ECG partners urged us to notice that value-based arrangements with the opportunity to be more fairly rewarded for your performance were out there on a national level, and likely would be coming our way, and we needed to prepare the infrastructure to deal with it, and indeed they were right. And the commercial payers did begin to consider these new arrangements, but we really were set apart as relevant and indispensable in our market because of our ability to demonstrate competency in those areas that Rachel talked about earlier. They are simply the right way to deliver care, using analytics, having the right framework behind it, et cetera. The last lesson that I would mention there is that basically, if your commercial market isn't ready for value-based care, as ours wasn't, the good news is Uncle Sam is ready. And there's big money in the Medicare system. CMS and the Innovation Center have multiple programs that offer solid reward for good performance, and those rewards let us do two things. Those dollars can fund the infrastructure that we needed to build to support this and do the right thing. And these rewards can keep your physicians both emotionally and economically bound to you, creating that technical term we use called stickiness. On slide 32, we've listed some examples of shared savings distributions across our system. This chart shows roughly 3 years of returns on a sampling of both commercial and Medicare shared savings. Let me comment quickly on the Medicare shared savings line you see there toward the bottom, MSSP. That is our ACO joint venture with another partner. And to give you an idea of the order of magnitude in the MSSP program, our ACO manages about 30,000 Medicare beneficiaries, and that accounts for about $300 million, probably north of that, in claims. In our last reported performance year, which was 2019, remember Jim's delayed gratification comments, our ACO saved almost $28 million over our baseline. And that 9% savings rate made us the best performing ACO in Pennsylvania, and with a quality score that was top 10 in the nation. And we're equally proud of that. Of course, we have to share those savings 50-50 with CMS. Our ACO kept a portion for its infrastructure, the hospitals get a share, and the bulk goes to the primary care physician community. But overall, this slide, you see we were able to return a little over $10 million to our hospital, which is very gratefully received at a time when you're intentionally deferring referrals or repurposing procedures to outpatient settings, et cetera. We were able to fund our DHP infrastructure to the tune of around $4 million. I think the next slide begins to show a little bit on a physician by physician or practice by practice basis what these dollars mean to the doc. So the specialty cohort, obviously much bigger than our primary care one, but the dollars to the primary care community, over $8 million distributed to them. It's about $400,000 per practice over a couple of years, but really significant funds to keep our primary care community safe from interloping other systems who would like to come and tempt them away from us, and takes the burden off the health system to have to support them going forward. The specialists, I say, much bigger cohort, smaller dollars per doc and per practice, but still something for them to see. And I'll just close with another example on slide 34 of the analytics that have become so important to us. We use these metrics like unplanned admissions and ER utilization rates in those compensation formulas that Scott described. And again, without access to these all episode raw claims data from the payers, we would have difficulty in being able to really push the care transformations and payment transformations that we need. So I think, basically we can provide better care, we can get paid appropriately for it. So value-based work has been a big success for us so far, and we still have a ways to go. But I think with that, Purvi, we're probably ready for some group discussion.
Okay, wonderful. All right, so at this time, we're going to jump into our panel discussion, and we're going to try to address as many questions that you all have. But please do continue to enter your questions into the questions pane, and we'll try to get to as many as time permits. And those questions that we are not able to get to, we will certainly address those questions once the webinar is completed. All right, the first question, I think, since this is probably appropriate for Sherry or Dr. Levy, the question is, can you share a little bit more about your experience as you leverage this type of contracting to create stickiness with your physicians, speaking to any sort of barriers that you did run into with the physicians?
Scott, you want to go ahead and talk a little bit again about the compensation models and the engagement with the docs?
Yeah, sure. So as I indicated, this started off with the clinical integration component. The financial rewards, the physicians previously had previous relations before DHP directly with a management entity that was from one of the major payers. And the concept that was always somewhat challenging is to assure that the practice is in a group where the performance is equally well. Now that the physicians are in an entity like DHP, the concern and some of the optimism was, how would they perform as part of our network versus directly contracting with the payers for a value-based contract? And ultimately, two things happened during this period of time. Number one, the physicians made it very clear that we had to invest significantly and robustly in infrastructure. Not necessarily infrastructure for DHP, but infrastructure to help with the value-based proposition, care coordination, filling some of the gaps that are required for some of these contracts. The practices had made a significant investment in this on their own. However, there's a lot of commercial entities out there that are promising physicians all sorts of infrastructure support to do that. So if DHP was going to be successful, we had and Jim talked about the delayed gratification, make a further investment in infrastructure. And the second part of that was to very quickly use data to demonstrate that DHP, because of the clinical integration, the performance was so strong as the entity that the physician groups would do better if working through a contract with DHP than directly through the payer, because they would be able to leverage our infrastructure and also the strong value proposition of the other colleagues within the group. And that's been demonstrated to be very powerful. We also used analytics to try to make sure we could improve groups that weren't performing well. We really tried to avoid taking practices and eliminating them from the entity because they weren't performing, but there was a lot of infrastructure and support for those practices. Compensation was reduced for practices that didn't perform well, and ultimately to receive what compensation they did, they had to demonstrate a performance, an improvement plan, and demonstrate that they were using the dollars they got to improve the practice performance.
Great, thank you. The next question is actually kind of along the same note here. Can you share some of your strategies for engaging physicians to lead this work as opposed to being pulled along or simply being a participant?
Hervey, let me start on that, and then I'm going to toss off to Scott. And the reason why I want to lead this or start this is that from the very outset, our strategic planning process was not a hospital strategic planning process. It was actually the lead agency was the PHO. So the physicians were at the very outset the shared owner of the strategic plan. And then as we built the Doylestown Healthcare Partnership, it's a shared governance model and a shared management model. And so they have been engaged from the beginning. This is like creating something that the health system comes up with and then sells to the medical staff. This is one that together we learned and made a decision about what would be relevant to our collective market and to our collective community.
A couple of tactics we employed, which I think were helpful along that regard. Number one, we started our most well-received and the most well-populated meeting is our clinical integration committee, which meets once a month, where we have group physicians from every specialty, primary care and specialists, to talk about ways to standardize process throughout the continuum. And that's something that's got a lot of engagement. Physicians are either participants and or have an equity interest. We have over 400 participating physicians. Over 200 physicians have an equity interest. To be part of the leadership, you have to be a member who has an equity interest. Physicians, we keep tabulation of all the physicians' engagement, attending meetings, participation in subcommittees, being chairman. And at the end of the year, based on the financial success, the managing committee, our board, determines a point value and $1 per point for physicians who've attended meetings. So they're not guaranteed money for attending meetings. Based on the performance of a year, we then attribute points and the physicians get paid no more than what their time would be worth, but it makes them feel that their time is valued, and that assures cooperation when they know they're being paid to attend.
And I would just add to that again, the critical importance that the role that data and analytics play there. When those physicians sit down at the table and you can bring problems to them with data to support it, they love to solve problems. They're scientists, and most of the time these agendas are driven by the physician members. There are lots of issues in the, especially transitions of care and handoffs between primary care and specialty docs, between the hospital and the community base. They have obstacles in their day-to-day routine, and they're delighted to have a forum to bring it where everyone can speak on equal terms.
All right, thank you. We still have a couple more physician-related questions, and then we'll pivot to another topic. But does DHP put physician compensation at risk within their value-based program?
So the answer to that, the physician and the models we have, all of the base contracts are directly with the payers. None of the physicians' base contracts are negotiated for DHP. So all of DHP contracts are in fact value-based addition contracts, and there's not any dollars distributed until the dollars are earned. One of the greatest challenges is because of the delayed gratification, we're talking about dollars that are accrued now for work that was done 18 months ago or 24 months ago. So to determine how to equitably attribute those dollars to the practice is a key part. But it's all based on the dollars coming in then. And most recently, we've come up with defined periods at which compensation is awarded, and our compensation committee is the one that determines how the physician pool of dollars is distributed.
Okay. So another question related to compensation is, what are the components driving the primary care physician's compensation? So in other words, how are base salaries determined, and are there other components to their pay besides distribution?
Yeah, so most of the practices, most of the physicians are independent physicians. So they earn their own compensation based on their own performance and productivity. And then the monies that are earned with the payers, it's typically based a lot on the MCR. That's a significant part of it. The contracts have their own quality initiatives that must be met unless DHP doesn't get paid. And that's a big part of where our infrastructure comes in place to support the practices to assure those quality measures are hit. And then the compensation right now, our main factors are MCR, admissions to the hospital, admissions to the ED, and keepage. Those are the 4 elements that we're using right now.
Yeah, I wonder if it may be mildly misleading when we use that term of compensation. Sort of sounds like the physicians are all employed by our network, which they are not. As Scott mentioned, they have their own independent base provider contracts with the payers. These are value-based lay-ons over and above their fee-for-service compensation. And then so the way we distribute those awards is our compensation model.
And also just to add a bit about the employed physician. So the employed physician is in that same pool, and just like some of those rewards are distributed to the independent practices, dollars are just with the same formulas distributed to the employed practices. And what we do as an employed system is just like the practice has overhead, we take overhead out of that and we share those dollars, those rewards with the individual physicians who are doing a lot of the work within the practice. So the employed physicians benefit with the same formulas as the community-based practices.
Great. And Jim, did you want to add anything to that? I know you.
Well, just so as it relates to base compensation for employed physicians that we employ, those are all done on appropriate fair market ranges. Their base compensation is established. It's the incentive they get by participating and performing within value-based agreements that additional dollars are earned.
Sherry, this next question is most likely for you. Does the CIN negotiate fee-for-service agreements for the full network, or do independent providers negotiate their own fee-for-service and the CIN negotiates just the value-based contracts?
That's correct. The CIN negotiates the value-based agreements unless there is a payer who has not operated within our market before. We're dealing with that situation today. We have a new entrant in a Medicare Advantage plan that does not have a network built yet. So this is our first opportunity to try to assist in the provider base agreements. But up to this point, we have only negotiated the value-based component simply because all of our payer plans are well established and our physicians are already participating.
So the next question is it a requirement that all providers join the same EHR?
No, it's not. We strongly encourage physicians to do that. There's some operational advantage as well as clinical and business advantages, because obviously using the same platform, specialists have a great clinical advantage if the entire record is at their fingertips. And they also have a financial advantage because they're within the network. Those referrals and that clinical communication is easier. So there's a strong motivation to do this. There are a number of practices that are in our platform, some sub-specialists, and we've actually developed interfaces because of the reasons I just described. But it's not a mandate.
You know, it sounds surprising to say that it is a requirement that you have an EHR. You would not think in this day and age that there would still be practices who are functional without one, but around our area, not within our DHP world, but we have colleagues in the field who are still operating on paper today.
All right. Dr. Levy, I believe you mentioned a few of these incentives when you were sharing your slides and some of the screenshots of the dashboard, but can you explain in more detail examples of the physician incentives that are being utilized for value-based care transformation and how those were selected?
So I'm sorry, I need a little bit more help with the question.
Examples of some of the incentives or the performance metrics that were utilized to help drive the transformation.
Yeah, so I'll give you an example. So primary care is somewhat easy because there's so much data available. Most of the contracts are capitated, so you know exactly the panel of patients and you can measure. For specialists, that's much more challenging. Episodes of care work in certain areas, such as orthopedics. We've been involved in bundle payment, but there's a lot of the medical specialties where it's commingled with care, and it's really difficult to flesh that out. However, we do know lots of various things. We know that heading to specialists to help in utilization of medications, the primary care docs are very heavily rewarded based on the use of lower cost, equally effective medications. Often it's the specialists who put a monkey wrench in that, because what they do is they ultimately use more expensive drugs. So getting the specialists involved in understanding which drugs are in formula, which not, to make sure they use appropriate drugs, and actually pull in some of these specialists who utilize very costly drugs and talk about are there other substitutes is very effective. Appropriate coding is critical to assure that the reimbursement matches the work that's being done. So having the physician, since we have one electronic system, having the physician understand the importance of accurate coding is the component. And specialist performance has been tied to attending sessions to learn more about coding effectively.
Thank you. Jim, this is a more overarching question that's been posed here, but what would you say is the biggest challenge your organization has faced in implementing value-based payment models?
Yeah, I think the biggest single challenge as we go through with this is to move the needle in the dialogue with the payer community, so that as we're able to do more, they're willing to pay us appropriately in contractual structures that value that. I'll give you an example. We put a lot of investment into care management infrastructure and data analytics. I know other colleagues who have gotten into some value-based issues and they go, why am I putting that in? The payer's doing that. They're already calling patients at home. They're already doing the care management issues. They're sending the docs information. We found that has, relative to performance, doing it ourselves and being more granular and being more explicit about that has absolutely impacted the performance for us. But you have to realize you're picking up additional costs that otherwise somebody else might be picking up as well. And so in a contract negotiation, how do you get the value for the work you're doing that the payer's not having to do and be appropriately rewarded for that? So today we're in a very exciting new discussion about a joint venture with one of our payers to potentially come together and do that in a more of a joint venture way than as two independent entities. And I think that but it's taken several years of performance and really earning your right to the table to have that conversation. But I think I would say that's probably the biggest single challenge. Early on, it was just the whole idea that help me understand why I'm going to be excited about keeping people out of the hospital when for years it was how many people came into the hospital. But in fact, if you do this right, we actually have increased our volumes into our hospital as a result of knowing where the leakage out of our system was and bringing folks back in and now being part of clinically integrated rather being fragmented and improving the cost. So you win both ways in this if you really use the data effectively.
Yeah, I think, another important piece to the puzzle is that sort of three-legged stool that Scott described before, of having the hospital and specialists and primary care all engaged at the table. When the physicians have their own financial incentive as part of the project, it makes a difference when they consider their referral patterns. And again, the data is there to show what's a more cost-effective skilled nursing facility. Is our facility the most cost-effective when it comes to certain procedures? Is a given specialist have better outcomes than another? And those primary care docs have some significant dollars on the table here, and they will use their referral power to optimize their own outcomes and performance. And it has made a significant difference. I think, it's really taken down the silo walls in both, again, quality and financial integration, clinical and financial integration. There are as many clinical breakthroughs as there are, financial smiles when it comes to some of our performance.
That makes a lot of sense. Okay, Sherry, this might be a question for you. So often organizations are becoming overwhelmed with the amount of administrative tasks that are associated with managing some of these value-based contracts. How have you all managed to minimize some of these administrative burdens?
Well, we work 24/7, but that's just expected, right? No, and seriously, it's I think using professional help when necessary is a real key for us. And we early on brought in a national consulting partner in ECG to talk to us about models that are out there and how they work, and to prepare ourselves for a new world order that we hadn't seen here in our market before. We've done the same with other things, periodically with analytics. We have a very robust clinical analytics team, but we use an outside actuarial firm for that. And you really do have to seek seek professional help initially when it's not one of your core competencies. But you know, our system CEO, Mr. Brexler, has been very clear that we need to build and ultimately own and control those competencies. So as we identify them, recognize them, rent them out temporarily while we learn, but our preference has been to control them from the inside. But we have a pretty lean infrastructure.
So along the same lines then of some of the support that you need to really be successful in these value-based arrangements, there is a question being asked about the data analysts, the pharmacists, care managers, and other population health staff. How are they paid for? Is it investment by the hospital? Is there some sort of pay-in from the physicians? Or is it a cut of the shared savings?
So it's a great question, and it's critically important. So early on, the hospital, as I indicated, supported all of the things that you listed, and we kept an inventory of the cost of those with an expectation over time they would be paid back. So we have our lead pharmacist that sits on our clinical integration committee. That's part of the organizational responsibility to provide that service. Analytics is very different. We have a very robust analytics department at the hospital. However, there are significant hours needed to create some of the modeling we showed earlier. And that is paid by DHP back to the hospital. The hospital provides the service and is contracted back, and DHP pays for that part of the service. It all comes out of the overhead that you saw. Is almost $4 million in overhead for the first 3 years to pay for a lot of those services for the staff that go out to the offices, et cetera.
Purvi, though, I want to add too, though, that we made it, again, this intentionality about going down this path. We made a decision to basically operate as if all the contracts were value-based even before they were, which meant the infrastructure we put in place were for all patients. The care protocols were across all patients. And therefore, a component of them went toward and were reimbursed by DHP when there was a value-based contract, and we could do that based on the amount of covered lives or the activity. But it also meant we leveraged those resources that the hospital was otherwise going to have as a health system for traditional commercial patients or for others that weren't in value-based. As we moved forward, it created even a better incentive to get everybody under a value-based contract. And as of today, we have about 90 to 95% of all of the patients that we care for in our system in some form of value-based contract, so that we're not trying to take care of some patients under a fee-for-service model and some patients under a value-based contract. The fact of the matter is that they all should be in a value-based model and deliver care appropriately. And that requires care coordination. It requires follow-up of high-risk patients into the community with nurses or telephonic support. And it requires data analytics to our network of physicians. So it's a leveraged resource to the entire network of care. But as Scott said, and was really helpful, it helped me a lot with my board when we finally started paying the dollars back for some of that infrastructure cost 2 years later. And now today it's a sustainable operation so that it flows appropriately.
Well, and Jim, I think that also speaks to just being able to treat all of the patients in an equal capacity, speaks to the reducing of administrative burden too on your organization. You're not trying to manage, which protocol applies to which patients and so forth.
And Purvi, one last point I really want to make on that is that you can get hung up in chasing the financial models, but if you focus on care and quality and efficiency of care and appropriateness of care, the financial models work themselves out. The challenge then becomes working with the payer to get paid appropriately for it. But why should we be making money on inappropriate care or inefficient care? We should be focused our organization across that, which also engages the physicians and all the other clinicians in a mission-driven sort of model, which is very different than I think some try to do when it's purely an economic model and they're chasing the dollar.
No, that makes sense. Thank you, Jim. I know we have a few more questions that have come through. We unfortunately will not have time to get to those questions, but rest assured we will reach out and answer those questions directly with you all that have presented these questions. All right, well, next I wanted to give the stage to Rachel, who's going to just speak to a little bit more about the other topics that we're going to address as part of this value-based series. You'll see that some of these really dive in further to some of the experiences that Jim, Dr. Levy, and Sherry have described for you all.
For sure. So on slide 37, again, just want to thank Doylestown for sharing all their insights. And just to remind the audience, this is part of a webinar series about value-based care. And this first webinar was really meant to give you all a framework to help you think through what, level of risk your organization is currently taking, and then how to get to the next level. And we heard a wealth of information from Doylestown Health. And the panel discussion, it just shows that there's a lot to consider when implementing these models. And to that point, ECG has 2 upcoming webinars to help provider organizations with more targeted issues, particularly around contract metrics and physician compensation. And so the next webinar will really help providers answer the question about whether or not your organization is leaving money on the table with your value-based payment contracts, and helping everyone understand if CMS is penalizing you for perhaps not achieving quality, patient safety, or patient experience benchmarks. So please join us on June 7th as ECG leads a discussion with MUSC clinical quality leaders, where they will discuss MUSC's approach to improving performance and quality metrics, and also share tactics that they're using to overcome some of the challenges so that they earn all possible incentives. And then after that, the next webinar will feature ECG's provider financial services leader, Josh Halverson, who will host a detailed discussion of how the new Stark and anti-kickback rules make it possible for your health system to become an agent for change within your market. Josh will share some success factors for value-based compensation plans under these new regulations, including structural options, commonly used performance metrics, and implementation considerations. And he'll also share why those innovative incentives should be viewed differently from an FMV perspective than a typical arrangement. And again, we heard a ton of questions from you all around both the metrics that you should choose, how to perform well, as well as physician compensation. So look out for some more communication from ECG about these 2 webinars. And again, we'll go into a little bit more detail now that we've provided you all with a framework to think through those different levels of risk. And with that, I will turn the presentation back to Purvi to close out.
Great, thank you, Rachel. So this concludes our formal program. Again, as Rachel stated, we would like to thank our panel from Doylestown Health. Thank you very much for a very engaging discussion today. Please note that if you did ask a question and we were unable to get to it, we will follow up with you after the session. We would also like to make you aware of ECG's extensive library of thought leadership. You can visit our website at www.ecgmc.com to learn more about these relevant and timely topics. And again, I would like to thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information that was provided in the handouts. And one final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a good day.